Thank you everyone for attending today's Science Cafe. Today we'll be focusing on ethical issues in translational science. I just want to take a brief moment to introduce the CTSC for those of you who are not familiar. So the goal of the CTSC is to improve the health and health equity of people who live in Northern Ohio and beyond by providing resources and services to our hospital and university partners, clinical and translational researchers and scientists, as well as community members. So the CTSC is currently doing this by focusing on these 5 key areas that you can see on the slide. So resources and services, community engagement, workforce development, clinical and translational funding opportunities, and then health informatics. And I want to take a moment to introduce our content experts for today. So we have Dr. Eric Kodish, who is a professor of pediatrics at the Lerner College of Medicine at Case Western Reserve University. After his fellowships at the University of Chicago in both pediatric hematology, oncology, and medical ethics, he joined the staff at Rainbow Babies Children's Hospital, where he was the founding director of the Rainbow Center for Pediatric Ethics. His areas of expertise include childhood cancer and blood diseases, pediatric ethics, end-of-life issues, and research ethics. And also with him today is Dr. Aaron Goldenberg. He is a professor, research director, and vice chair in the Department of Bioethics and Medical Humanities at Case Western Reserve University School of Medicine. Dr. Goldenberg's work focuses on ethical, legal, and social implications of advances in genomics within clinical and public health settings. His research program has been grounded by a number of major project areas that include ethical implications of expanding newborn screening programs, the storage and use of perinatal and pediatric biological specimens for future research, as well as the implications of genomics for communities experiencing health disparities. So I will turn it over to both of you.
Thanks, Mackenzie. I'm going to go first and then hand it over to Dr. Goldenberg. I appreciate the introduction, and those were good days at Rainbow. They were a long time ago, though. It was 93 to 2004 when I was privileged to take care of children with cancer at Rainbow and begin my research career. And I've been at Cleveland Clinic since 2004. I came over to chair the Department of Bioethics and really focused the last 5 or so years, 8 years of my career on mentorship and education, which is also a privilege. So it's great to be here today. I'm going to talk about some research ethics fundamentals, and then we're going to do a couple of fun participatory polls. It looks like we have 30 folks on the line. So everyone gets to vote on a couple issues, and then I'm going to pass the baton to Aaron. I have a consulting relationship with Insight. I serve on their data sharing committee. Wanted to make that disclosure. Doesn't affect this talk at all, but I'm an ethicist, so we disclose. In the beginning, words express the way we think, also affect how we think. So I want to start with this idea that language really matters when it comes to fundamentals of research ethics, and translational research is actually a really interesting word combination. If you think about it, in the early days of research ethics, I was privileged to sit with some of the leaders in the field, and there were arguments, vicious arguments, about whether we could use the word therapeutic research or if that was confusing to patients, and maybe we should say research with the prospect of direct benefit instead of therapeutic research. But translational research sort of, obfuscates that debate a little bit, which I think is interesting. So the language really matters. Bob Levine, who was very intense about saying that we should not use he actually, I think, favored the phrase therapeutic research, wrote this important book in 1986. Research is a class of activities designed to develop or contribute to generalizable knowledge, and practice of medicine is solely to enhance the well-being of an individual patient or client. So if you look at it that way, anything that involves any amount of gaining knowledge, all of translational research is really thought of as research. And if you're purely looking after patient with no intent to learn anything, you're doing practice. And we have this whole concept now of the learning healthcare system, which also, makes things more interesting. So I'm going to go on here to other words. Doctors care for patients, researchers study subjects or participants. And whether you choose the word subject or participant is kind of interesting, right? If an individual is enrolled in research, do you think of them as a subject? That was sort of the older way. Or are they active partners? Are they a participant in the research? And if it's a clinical trial, are they a patient? How many patients do you have in the study? Well, to be a purist, they're really either a participant or a subject. And this is not to say that that they're incompatible. There was an older way of thinking about things after the Tuskegee syphilis National Health Service study came to light, and the abuses of the Nazi doctors, et cetera, that we need to protect people from research risk. And then in the 90s, mostly, there was this idea that we need people to have access to clinical research, and they are participants. So I had the privilege of speaking on Monday to our graduating medical students at CCLCM, and I reminded them of this F. Scott Fitzgerald quote, which I'm going to read here also. Some of you may have heard this. The test of a first-rate intelligence is the ability to hold two opposed ideas in mind at the same time and still retain the ability to function. So the two opposed ideas here in this context are that we're doing research and people are in need of protection for research, but also that it's important to give people access to clinical trials because sometimes that doesn't portend danger for them. It actually gives them access to the latest and potentially best medical treatment. So that's by way of introduction. We're going to get to a poll here in a minute, and I'm going to get your opinion on this. But to set up that poll, I want to talk to you about the Belmont report, which came out after the Tuskegee experiments came to light and said the three fundamental ideas in research ethics are respect for persons, beneficence, and justice. And the issue of the intermixing of goals here, the Belmont report addresses by saying this need not cause any confusion. Whenever you see something says this need not cause confusion, it probably is going to be a confusing thing, right? And the Belmont report says these things can be carried out together. This need not cause confusion about whether it requires review. This is IRB review they're talking about. The general rule is if there's any element of research in an activity, it should undergo review for human subjects protection, right? Now, the World Medical Association in the past has put forth a Helsinki Code. The Helsinki Code still exists. They got rid of this piece of it, but I quite like it and wanted to include it here for your consideration. Helsinki says, in the field of biomedical research, a fundamental distinction must be recognized between medical research, in which the aim is essentially diagnostic or therapeutic for a patient, and medical research, the essential object of which is purely scientific, without implying direct diagnostic or therapeutic value to the person subjected to the research. So keep that in mind and look at this for a second, which has, can you guys see the arrow? Mackenzie, is the arrow showing up here? No? Okay. Well, on your right-hand side is non-therapeutic research. Something that is done purely to study physiology, let's say giving a new drug to a healthy subject and measuring levels of them, but it's not a subject who has a disease for which the drug is intended to be treated. You can imagine a number of other non-therapeutic research things that do carry with it some amount of risk. And Helsinki says the line is here, and research with potential clinical benefit on the left and medical care should be considered together. The Belmont report, as you see on the left, draws a line in the other place. It says medical care is one thing, as I showed you before, but all research, whether it's therapeutic, potentially therapeutic or non-therapeutic, is there. So the poll question for you is, where would you draw the line? Are you in alignment with Belmont or Helsinki? And in ethics, it's not enough to just answer the question, but you have to say why. No one's going to be able to say why in the poll, but please go ahead and vote, and then maybe we can talk a little bit about the why. And Mackenzie, once people have a minute to consider this and deliberate on their answer, we'll share the results. And then I think in the chat, maybe people could write about why they answered what they answered. There's a request to put the previous slide back up. Someone, my previous slide. Yeah, is that, hopefully that answers, is that? So is the line the one on the left, or is the line the one on the right? And what I didn't give you an option for in the vote is someone could say, well, we should have three separate categories. We should think of therapeutic or clinical research as a third category. Mackenzie, do we have some results? And I don't want the Electoral College, I want the popular vote.
Yes, it looks like, so we have 17. So I guess, yeah, take the last few moments. Oh, I do see there's a few more people responding. So I will, yeah, end it in like 10 seconds. So if you want to answer, there's 20 responses right now. Okay, I will end it and now share the results here.
Okay, thank you. So the winner by 2/3 to 1/3 is the Belmont report. Is anyone willing to either unmute or put something in the chat about why they voted like they did? Minority opinions are very important, and certainly would love to hear from someone in the Helsinki crew or the Belmont crew, or both. And if you can hit close, I think, or can I hit close? Okay, I closed that off of the screen so people can see the slide. So any thoughts about the why? There's someone in the chat. Oh, let's put the previous slide back. Did y'all just flip a coin, or were there thoughts behind it? Nora.
So I think that the mindset ought to be to see research as part of medical care unless it's clearly not going to benefit directly somebody, because because raising the level of care is so integrated to understanding the current standard of care versus if you can improve on that.
So it sounds like you voted for Helsinki. Okay, anybody who wants to argue? I know Dr. Singer loves to have counter arguments and expand her thinking. Who wants to say why Belmont might be a better approach, which is our current approach in this country? Anyone? You can chat if you're shy. Dr. Cole says, Belmont, a volunteer needs protection regardless of the type of research. Thank you for that. Right, it's a I think reflection of some historical sensibility, and maybe that we need to stay vigilant because it these research catastrophes could happen again, and trust is a very fragile thing in the public mind. So we want to prevent anyone from being exploited or harmed hurt in research if we can. But there is some risky research that goes on for sure. And I'm glad to have the chance to hear sort of both sides of the argument. Last chance for someone to say something, either on the chat or in vocally, and then I'm going to move on. Okay. So the current Helsinki code goes along the lines. The primary purpose is to generate new knowledge. This goal can never take precedence over the rights and interests of individual research subjects, and physicians who combine research with care should involve their patients only to the extent that is justified by its potential preventative, diagnostic, or therapeutic value, and if the physician has good reason to believe that participation will not adversely affect the health. So that's a very different approach than the American system, which really, again, I do pediatric research ethics mostly, where there are additional protections for children, but on the adult side, there's no upper limit to the amount of risk adult who provides informed consent is willing to undertake. And this Helsinki has some guardrails against it, I think, that are quite nice. So I want to just mention also, before I hand it over to Aaron, the 4 principles of biomedical ethics and contrast those with the Belmont report, which I showed before. You'll see that non-maleficence is sort of disappears. It goes inside beneficence, in my view. But the thing I really want to point out is respect for autonomy in clinical ethics is called respect for persons in research ethics. And this is a key idea because, again, the Belmont report now says respect for persons means that individuals should be treated as autonomous agents, but also those with diminished autonomy are entitled to protection. So you see this protective sort of orientation to Belmont. And this appeals to me, again, as someone who thinks it's important to do research, even with young children who can't consent. We need to show respect for them. It's more robust than autonomy, and their vulnerability may demand greater attention even to our other ethical commitments. So one simple way to look at the Belmont report in action is to say that we manifest, we show our respect for persons by taking informed consent seriously. Don't have time today to do a deep dive of informed consent, but it's an area of great interest. And if you really want to geek out on it, there's a fantastic book called History and Theory of Informed Consent by Tom Beechin and Ruth Faden. Beneficence is by doing a good risk-benefit assessment, and that's our job as investigators and IRB's jobs, I think, and to not present overly risky research for which patients might consent. It's a paternalistic or parentalistic sounding thing, but I think it's a very important way to demonstrate our commitment to the Belmont principles. And then justice in participant selection. I will share with you that I up until a few days ago, sat on an NHLBI external advisory panel, scientific panel to try to cure sickle cell disease, and the current NIH leadership, in its wisdom, has shut down that committee. So minority populations like patients with sickle cell disease, I think going forward are going to have fewer options to participate in. And in my view, that's a real justice problem. Sickle cell disease, again, could be a whole nother topic for a seminar, but one example of where justice is very important. The last poll is going to have to do with informed consent. The 4 components are competence, disclosure, understanding, and voluntariness. And to be totally fair, competence is more of a prerequisite, and the other 3 are process-based criteria, but they're all standardly sort of thought of as the elements for valid informed consent. So here's the second poll question. You guys have the juices flowing now, hopefully. Which of the 4 elements of informed consent is most important for research participation? And we'll give it some time for you to vote. hopefully these concepts all sort of speak for themselves. I realized because of time constraints, go into each one, but I think this is a pretty sophisticated group. Mackenzie, are we getting any votes in?
Yes, 25 people have responded. Now we're up to 27.
Love it. This is great. Okay, let's go ahead and show the results so we can move on to Dr. Goldenberg's section. Wow, very nice, even distribution, right? But it looks like the winner is voluntariness, and that reflects maybe people's concern that participants may be coerced into participating in research. And when it comes to medical care, right, voluntariness is also important, certainly. But there are cases, at least in pediatric ethics, where we override the dissent of a young child for something in their own best interest. For adult medical ethics, not so much. But research is something where we take voluntariness to be extraordinarily important. Understanding also, I think, gets quite a lot of votes. And the truth, of course, is that all four of these things are very important. They wouldn't really hold together as a holistic informed consent conceptually if you were to remove any of them. Any comments or chats about the elements of informed consent? I see Carla Greenwood mic off, or is that just a random mic off?
I can add something. I picked competence because I feel though if there is no competence, you just can't move forward with the informed consent process. So that in my book is the most important.
Great, thank you. It's a very, very good point. It's as I said, more of a prerequisite. So if you think someone isn't competent to make a decision to participate in research, what are the options then?
Hi, everyone. I picked disclosure because I feel in research is very important, the transparency to, have the participant really trust the system. And, this goes back to, historically, as research emerged and all the, Tuskegee study and all that. And in order to gain more participants, I feel disclosure, it's quite important. I wish we had a option to pick two because voluntariness is another one that I would pick.
Thank you very much. Right, disclosure, and when I teach informed consent, I always make a point to say you can't disclose everything. Consent forms are incredibly long and abundantly, disclosing usually, but in the process, which is really important, you talk about risks, you talk about benefits, and you talk about alternatives. And I think that applies both in the clinical realm of informed consent and in the research realm. But certainly the benefits in the research realm are both benefits to the potential participant and benefits to other individuals. And then just back to the competence for a second, I asked a rhetorical question a minute ago. What would the options be for someone who's not competent? And one would be to just not do the research, which is fine. I think we all get very zealous about doing more and more research, but it's okay. Research is supererogatory in the end, as opposed to clinical care, which is more required, generally speaking. But the other is you can, if there's an appropriate surrogate decision maker, they can provide permission for someone to be involved in research. And again, we do that in pediatric ethics all the time. And Dr. Singer says LAR for incompetent thought. Temporary incompetent where not practical to have consent, trauma, blood alternatives in the field community needs to be informed. Nora, do you want to say anything more about that? I'm not sure what LAR is.
But isn't that the legal representative? The legally
Legal authorized
Yeah.
representative, yeah.
Yeah. So we did a study here with Pittsburgh where non-blood products were being used to replace blood in the field because it can be, unlike blood, it doesn't expire in the same amount of time. And because many of those patients would be unconscious without time to properly consent the next of kin, there was community education required by the IRB that was pretty broad to know this study was going on, and that was used as a substitute when rapid informed consent could not be obtained.
Right, that's a great example. Super fascinating, and will sort of segue nicely into Dr. Goldenberg's comments, I think, about what constitutes a community and who, is that sufficient and how is that sufficient? So I'm going to zoom through the end of my talk here. One way to think about protection is the 3 I's. You can do investigator integrity, and IRB approval, and informed consent. These are all ways of protecting human subjects. My editorial comments are here that investigator integrity is the most effective way to protect human subjects. Informed consent, and I've studied informed consent, like with NIH-funded empirical studies of consent. It's not really very effective at protecting subjects. It's very enforceable, at least in terms of the document, because if someone signs a document, you can monitor that on a research audit. IRB approval is kind of in the middle. It's pretty effective, I think, and a little bit more enforceable. And I think the 3 I's is a nice way to think about protecting human subjects. These are the guts of the regulations. Again, without the special populations of prisoners or pregnant people or children, this is for adults of sound mind and body, so to speak, or sound mind, I should say. The risk has to be in proportion to the benefits of knowledge, but it doesn't say there's no limit. It doesn't say there's a limit to the risks. If it can bring a lot of benefits and knowledge to other people, adults can be exposed to a lot of risk. You do have to maximize safety. This is a justice issue. Informed consent we've talked about, and a quick taxonomy of clinical trials. I think most of you probably know the differences between phase 1, phase 2, and phase 3 trials. But this is a reminder to me to mention equipoise as a moral requirement for a randomized phase 3 trial, and to express some concern about what's called therapeutic misconception for phase 1 trials. Again, I don't have time to go into TM too much, but an important concept in research ethics. And just to conclude that these are both important. Again, it's back to F. Scott Fitzgerald. We have to hold both of these in our mind. Improving treatment is important. Protecting people from research risk is important. Sometimes they conflict, but we have to function through that. I think risk-benefit assessment by a good IRB is more effective than informed consent. And the biobanking issues are, I think, fairly different than the clinical research issues. And I will pass the baton to Dr. Goldenberg to talk about some of biobanking and other issues. Thanks. Look forward to some questions maybe at the end.
All right. Thank you so much, Dr. Kodish. It's just an honor to be with all of you. I'm looking forward to some conversation at the end, so I'm going to try to get through my slides fairly quickly. When thinking about this Science Cafe, we wanted to try to make sure to talk about what we kind of saw as the fundamentals, the foundations of research ethics, which I think Dr. Kodish covered really, really well. We also wanted to try to challenge us a little bit as a community to think beyond research ethics and to think a little bit more about other ways in which ethical issues can be integrated across translational science, and thinking critically about some of the ways in which things like equity and ethics and justice can be integrated into really the foundations of what we do as researchers and what we do as a community. So, here are kind of those traditional ethical issues that we've been talking about today. So thinking about, issues of privacy, issues of consent and enrollment to our studies, issues of benefits and harms and weighing benefits and harms. And, these kind of traditional principles are used in all sorts of translational research, all the way from basic science, clinical trials, and even in the kind of storage and use of tissues and samples for future research. But what we've really seen over the last really 30 to 40 years since the Belmont Report in Helsinki were established is kind of an evolution of translational science to really think not just about those kind of traditional research ethics questions, but to include other aspects of ethical, legal, and social issues in translational science. And that includes things like community engagement and diversity and equity, issues of stewardship and data sovereignty. How do we become good stewards of our data? Something I'll talk about in a few slides. Issues of return of results and what kinds of systems do we need in place to do an adequate job of explaining research results to our participants who are ultimately going to be patients. And what I want to do is try to raise a couple, I would say, challenges, but issues that I think we as a community need to confront in order to do a more holistic integration of these kind of wider ethics issues and values issues throughout translational research. So, for me, especially with some of the challenges we're seeing in terms of federal funding and issues related to regulatory structures, I think it points to the need for more structural changes, and that those structural changes are things that we do collaboratively across research projects, across institutions. One of the things that comes up a lot in translational research, kind of one of the core tenets of our CTSC, is to diversify our research cohorts. And we see that as an ethical and moral obligation to try to think about diversity within our clinical trials. However we think about diversity, whether that's racial and ethnic diversity, whether that's rural and urban diversity, whether that's different disease states, however we think about that diversity, it's something that's kind of core to who we are as researchers. But I do think that over time, there's been kind of an over-reliance on diversity and recruitment as a means to somehow ethically address equity issues or ethically address disparities issues. And if we look at kind of the last 30 years of ethics integration into research, a lot of it has been focused on this idea of diversifying our research projects, especially over the last maybe 5 to 10 years. But I think what we need to be doing as a community is to be thinking a little bit beyond inclusion to better integrate ethics across the translational pipeline. Doesn't mean that inclusion is not important. Of course, it's important. Of course, thinking about diversity within our research is something we need to be continuing to try to promote as much as we can. But I think, given a lot of different factors, we need to be trying to think more broadly about ethics and equity throughout the whole translational pipeline. If we're going to really figure out a way to have our work translated into benefits for all communities, we have to be thinking about this kind of much broader sense of ethics and equity in our research, all the way from building research and databases and our cohorts to doing that basic science and clinical trials, to even how we distribute our results, how we think about translating our results to the bedside and benefiting patients. Just a little bit further, why I think over-reliance on recruitment is potentially problematic. One is because it's often seen as the end goal. The idea is, well, we'll get diverse participants into our research studies, and then the rest of the translational pipeline will take care of itself. But what that means is there's a lack of community input and dialogue about things like who can access samples and data, how do you prioritize research questions, how do you interpret results and make sure they're relevant for our for the Cleveland community, for other communities, and how do you make sure that we have benefit sharing? All of these things are essential in many of the foundational ethical principles that Dr. Kodesh talked about, but I think need to be expanded throughout our work in a much more holistic way. And the problem is because if we don't, then diversity and those kinds of that kind of work becomes just window dressing, right? It doesn't actually guarantee benefits for really any communities, especially underrepresented or medically underserved communities. We also see, and we see this a lot here in Cleveland, we see this other places, that by not more holistically thinking about ethics and equity across the translational pipeline, we may further alienate communities who already have mistrust of research institutions. And I'm going to talk about trust in just a minute. And it could lead to an underappreciation or the lack of integration of social determinants of health into our research, and generally lead to a potentially devaluing of our participants. If we look back at the Belmont report and Respect for Persons, that was really specifically targeting individuals, the respect for individuals. But over time, there's been a wider interpretation of that respect for individuals to also respect communities, to think about cultural, religious, and different traditions of our participants, and think about potential benefits and harms to communities in addition to individual research participants. And all of this, if we don't attend to these things, become a barrier to fulfilling the promise of research benefits for everybody, for all communities. We know, and we talk a lot about in our work, kind of what I'm calling a cycle of mistrust. And that may be mistrust in our medical system, that may be mistrust in researchers, or it might be mistrust because communities feel excluded from research. A few years ago, we did a study where we talked to individuals in the Cleveland community around health disparities, genetics, participation in research. And we heard some really amazing voices, some really amazing opinions from our participants. And I'm an empiricist, so I always have to present some data, even though it's not mainly a data-focused presentation. But I think you can kind of see this nuance of trust across these different quotes from our participants that really kind of show different sides of where we are in this cycle. So we clearly have kind of mistrust of research and medical institutions in the first quote. There's a mistrust, and I think it comes back to not even a conscious mistrust, but in the past situations where Black people were used as guinea pigs. There's also on the other side this idea of not being asked. So on one hand, not wanting to be used as a guinea pig, and on the other hand, wanting to be included in research. So this person says, they never asked me. I'm sure no one would ask me. This is about research participation because you didn't have anything to contribute to this research. This other participant underneath says, I wouldn't participate because my level of participation in study is at its lowest level. I don't get to make any decisions. I'm not in the planning. I'm just a guinea pig. And then finally, if we think about benefit sharing, we have a quote from one of our participants who said, whatever you're doing the research on, is there a guarantee that the outcome will work on the Black community? So again, all of these quotes are meant to kind of think a little bit, take a step back and think a little bit about, well, what does mistrust actually look like? It's not just mistrust, I don't want to participate in research. It's a real duality of, on one hand, not being mistrustful and not wanting to be used, and on the other hand, not wanting to be left behind, not wanting to be excluded from research. And I think as a community, as a translational research community, we have to find a balance between, on one hand, not using our participants, and on the other hand, not leaving them behind. And I think we've done a good job as a community. I just think it's something we need to think about more. And part of that has to do with what I'm calling the difference between community outreach and community engagement. We do a lot of outreach. We do a lot of education about our work. We go out, we talk about our work. We try to think about ways that we can increase participation in our research among patients and the Cleveland community and elsewhere. But I think we need to build new models that move beyond just outreach for enrollment and think about really engagement models that are kind of more foundational in nature. We need to rethink the researcher and participant foundational relationship. Those of you who know Erica Trappel here at CASE maybe know about the Cleveland African American Prostate Project. Happy to talk more about that. But that was really a community-based participatory project to increase prostate cancer screening in African American men, working with barbershops all over Cleveland. And the goal was really to create a much more centralized researcher participant partnership rather than a top-down research study. And that doesn't always work for every research project, but I think we, as much as possible, can take some lessons from community-based participatory approaches to think about how we can involve communities in providing input on how we collect data, what we're collecting, thinking about the analysis and data sharing, thinking about, how do we follow up and what the potential policy implications of our findings are. So I think we need to be moving beyond, the idea of community outreach and thinking much more about engagement itself, and really thinking about this as a two-way engagement rather than a one-way engagement. There is a lot of work being done right now on the distinctions between what we would call transactional and transformational relationships in translational research. It's a lot of translational, transformational. But the idea being that many of our relationships with our participants and with the communities from which our participants are drawn are much more transactional in nature. We go to communities, we recruit, we get participants for our studies, they get maybe financial compensation or other kinds of compensation, and they're very focused on a particular study. And there's been a lot of work in translational science to move us beyond transactional relationships to ones that are more transformational. And what that means is kind of building partnerships based on common goals, not particularly a study. So that means doing engagement even when there's not a particular study to engage upon, but just to kind of bring researchers and community members together. It includes thinking about how to integrate patient or community perspectives throughout the research pipeline, rather than just a surface nod to, oh yeah, we talked to community members before we did this study. It means much more holistically incorporating community perspectives in the design of our research, which is a little departure from a lot of what we do on a day-to-day basis, but I think can really lead to much better kinds of research. And it is really focused on building relationships. And I know many of you on this call, I recognize many names, are doing this with your research communities, but I think we can be doing this more. Just to finish up so we can get to some time for some discussions, I want to talk about some other what I'm calling neglected ethical issues. And we heard about this in a study that we just recently completed called Addressing Ethical Issues in Network Biorepositories, where we spoke with biobanks and large biorepositories across the country about things that they saw in translational research and biobanking that they thought were ethics issues that got ignored by many ethicists. Of course, they brought up issues of privacy and consent and the kinds of things that we've been talking about today, but they wanted us to talk about a couple other things that they thought were really important to establishing ethical guidance for translational research and biobanks in this case. And the first one was funding. They saw funding as an ethics issue. They said, if you're cutting personnel, if you're cutting costs, at what expense? How do you get research done? How do you do good work? And how do you support our community if we're having to always cut and always having to worry about funding? Similar to that, they felt the same thing about sustainability. So, for example, a lot of biobanks that we worked with were really worried about if funding went away, what happens to the data? What happens to the samples? Is there really a sustainability plan? Most biobanks that I've worked with do not have sustainability plans. Most research projects that I work with do not have sustainability plans if funding goes away. And so how do we create a sustainable network where data isn't wasted, data doesn't go away? The third issue they brought up was one of, if you build it, will they come? There was the concern that we're spending a lot of money and a lot of time building repositories or research institutions or research networks, and are people actually utilizing the data? And so this person, this biobank said, my goal is not to have 250,000 people in our repository that's not being used. So this kind of combination of funding, sustainability, and utilization were brought up repeatedly as ethical issues for translational research by our participants. And then finally, this one of stewardship is one that I think is something that we here in Cleveland, I think, take very seriously, but is something that I think we can also be thinking a little bit more about, is how do we see ourselves not just as researchers, but as stewards of our data, holding our research participants' data, holding the data that we get from our studies in stewardship for better health and better communities. And this is a quote from that Community Voices project I was talking about earlier, where we were looking at health disparities. At the end, one of our participants said, speaking about health disparities research, said, it's really important to be, I'm jumping ahead. This person said, it's really important to be thoughtful about participants as real people who are on equal footing to scientific researchers when you're setting up a biobank. that scientists' needs and desires can't trump the needs and desires of people that these biobanks are meant to clinically serve, or the communities that they will eventually serve. And I think that's really essential for the way we think about our work. Here's the quote that I was thinking about, which is this idea of really being forward thinking about our work and creating action plans with our community. So I'll start with a quote at the bottom, and then I'll move back up to my kind of strategies for integrating ethics. So this person said, I'm very frustrated with these kinds of focus groups and studies, because guess what? All of you guys know this already, speaking about health disparities. You're smart. Cleveland Clinic knows, Case knows, University Hospitals knows. Yet when you go into the community, we're talking about it and there's nothing being done. I hope that when these young ladies come back next year, this is referring to my research assistants, instead of some lofty report that you want us to read, and we will, but there'll be a true action plan. And this is really where I think I want to end, which is to think about strategies for integrating ethics have to be represented in real change, real structural changes in how we do research. First, I think we need to promote more transdisciplinary research teams. That means partnering with bioethics, medical humanities, other social sciences in our work. We tend to silo the work that we do with many of the studies that you all do. I think there's tremendous opportunity for us to work together and to think about these issues. I think we need to change the way we think about trust. We tend to talk about trust as, well, we got to get the community to trust us. We have to get our research participants to trust us. There's been a real shift in the bioethics literature and in the work that I'm doing to move away from issues of trust to ones of trustworthiness. How can we as an institution, how can we as researchers become trustworthy? It puts the onus on us to transform, not just, it doesn't put the responsibility just on our participants to just trust us. It really has us looking at ourselves and what kinds of things we can be doing as institutions to become more trustworthy. And then finally, really this idea of promoting ethical stewardship of our participants' data across our translational research pipeline, and to do so together. I'm going to end there. I'll just want to say thank you to some of the other folks in my center, Marcia Michie, Lynette Girardeau, and Roselle, who helped put this together. Here are some papers that we've published lately on some of the similar issues. And I want to just do one last shout out to our CTSC voucher program. There are opportunities that you can come work with bioethics and bring in some expertise, get some feedback on your studies that might help you to design and carry out your studies in ways that integrate ethics more fully. And Dr. Kodish and I are very eager to work with all of you and to think about ways that we can help you to integrate issues of bioethics into your work. And we're already doing a few of these consultations right now, and they're really fun and interesting and inspiring. And if you're working on projects and you would love more bioethics to be integrated, it's something that we would really love to do more with you. Thank you all for being here. And I know that Dr. Kodish and I are happy to chat with any of you anytime. And there are a number of opportunities to get involved in bioethics or have us involved in the work that you're doing and getting feedback. And we're hoping that this can lead to lots more collaborations with all of you.
And thank you, Mackenzie, for pulling this together and putting the polls and slides, et cetera, together. Appreciate it.
Oh, of course. And thank you for such a great session. I will send a follow-up email with both of your email addresses in case people want to chat with you further. And then, yeah, just the QR codes that are on the screen. So the left one is for next month's session, which will be on women's health with Rachel Pope. And then the middle one here is for feedback from the session today, or if you have any suggestions for future topics, that would be greatly appreciated. And then the last is to become a member of the CTSC if you aren't already. And I see a lot of thank yous in the chat. So thank you everyone for joining us today.